Okay, so we're moving into Chapter 5, Controlled Substances Part 1, and we're going to talk about the Controlled Substances Act. So the first section is going to talk about controlled substances schedules. The DEA, which is the Drug Enforcement Administration, under the United States Department of Justice, or the DOJ, enforces the requirements in the Controlled Substances Act, or the CSA. The DEA publishes the Pharmacist's Manual, which includes the details needed to comply with the Controlled Substances Act. The Drug Enforcement Administration, which determines which drugs should be classified as controlled substances, and then places them into one of 5 schedules. So there's Schedule 1, 2, 3, 4, and 5. The schedule is determined based on whether the drug has a currently accepted medical use, its relative abuse potential, and the potential for it to cause dependence when abused. The higher the abuse potential, the lower the schedule number. So for example, Schedule 1 drugs have the highest abuse potential and are considered to have no accepted medical use. Drugs in this category, such as heroin and LSD, may be used for research purposes, but they are most commonly used illicitly, which means that they're used illegally and unlawfully. Marijuana is an exception. It is classified as Schedule 1 according to the DEA, but it is available for medicinal and adult recreational use in the state of California. Then there are Schedule 2, 3, 4, and 5 drugs, which are considered to have currently accepted medical uses with varying degrees of abuse and dependence potential. Recognizing common controlled substances by brand or generic name will be important on the exam, on the law exam, the CPJE. So we have a table starting on the next page, which includes common drugs within each schedule. So looking at this table, we're going to reiterate what we just talked about. So when we're looking at controlled substance schedule definitions, we're talking about Schedule 1, and it's defined as having no currently accepted medical use. There's high potential for abuse and lack of accepted safety under medical supervision. When we're looking at Schedule 2 drugs, these are defined as having high abuse potential, and abuse may cause severe psychological or physical dependence. When we look at Schedule 3 drugs, these have a lower abuse potential than Schedules 1 and 2. The abuse may cause moderate or low potential for physical dependence or high psychological dependence. When we look at Schedule 4 drugs, this also has a low potential for abuse relative to Schedules 1, 2, and 3. The abuse may cause limited physical or psychological dependence relative to Schedules 1, 2, and 3 drugs. And then looking at Schedule 5 drugs, this has low potential for abuse relative to Schedule 1, 2, 3, and 4 drugs. The abuse may cause limited physical or psychological dependence relative to Schedule 1, 2, 3, and 4 drugs. So now we're going to look at some common controlled substances according to their schedule. So Schedule 1 examples include MDMA, GHB, heroin, LSD, peyote, mescaline, and technically marijuana, although it is legalized in some states. Schedule 2 medications include codeine, fentanyl, hydrocodone products, hydromorphone products, meperidine, methadone, morphine products, oxycodone, oxymorphone, tapentadol, sufentanil, and paregoric products. Then it also contains in Schedule 2 the ADHD medications, which would be amphetamine, dextroamphetamine, like mixed Adderall salts, the dextroamphetamine, which is in Dexedrine. It would include methylphenidate, which is Ritalin and Concerta, Daytrana, Quilivant, Jornay, PM, Quilichu ER. It also includes the Lisdexamphetamine, which is what's in Vyvanse, as well as dexmethylphenidate, which is what's in Focalin. And then some things that are used like in anesthesia, would be, let's see, some of the barbiturates, pentobarbital, secobarbital. Then again, it reminds us of Marinol, which is the dronabinol solution. Usually the Marinol comes in the capsules that are kept in the refrigerator. Moving into Schedule 3, we're looking at a lot of the medicines that would be dispensed under Suboxone, and Suboxone is the buprenorphine naloxone combo, and then the Butrans patches or the buprenorphine patches. The migraine medications like butalbital containing products, and the generic Fiorinol, which is butalbital, aspirin, caffeine. Tylenol number 3, which is the acetaminophen with codeine. Again, the Marinol is listed here, which is the dronabinol capsules. Ketamine, like if you're ever using ketamine for PTSD or sleep, ketamine is listed under Schedule 3. Let's see what else we have. There's a lot of patients that use testosterone products, like injectable testosterone, depo-testosterone products. Those are all considered anabolic steroids, and those are listed under Schedule 3. Moving into Schedule 4, we have the benzodiazepines and the sedative hypnotics. So we're talking about Xanax, and we're talking about Klonopin and Ativan, Restoril. We're talking about Lunesta, Ambien. We're even talking about the phentermine products and the Qsymia product for weight loss, which is the phentermine topiramate combo. And then we get into some of the medications like muscle relaxers like Soma, which is the carusoprotol. We're talking about Nuvigil, which is armodafinil, and provigil modafinil, which are for promoting wakefulness in people with like shift work disorders. We're also looking at things like Lomodal, and we're looking at here under Schedule 4 Tramadol, Ultraset, which is Tramadol with Tylenol. Then moving into Schedule 5, you start to look at things like codeine-containing cough syrups, so Cheritessin, AC, promethazine with codeine, Lomodal actually is considered Schedule 5. The other one in Schedule 4 was actually Motofen. They look similar, but they're slightly different. So Lomodal is actually considered Schedule 5. And then we're looking at Lyrica. Lyrica is the pregabalin. And let's see. So we just finished going through the chart, so we'll go ahead and continue here. So in terms of schedule changes, the DEA can reclassify a drug schedule with the perceived risk of abuse or dependence associated with the drug changes. When a scheduling change occurs, a pharmacy must complete an inventory of the drug on the date the change becomes effective. After the initial inventory, subsequent inventories are conducted according to the requirements of the new schedule. So there can be state-specific scheduling. States can choose to classify drugs into stricter scheduling categories than the DEA. When state and federal pharmacy law differ, the stricter law should be followed. Then there's formulation-specific scheduling. So most controlled substances in the same pharmacological class or containing the same active ingredient will be classified in the same schedule. So for example, all benzodiazepines are Schedule 4. Some controlled substances that are available as single entity and combination products, for example, oxycodone are Schedule 2 in all formulations due to the abuse potential. Other drugs, example, barbiturates, codeine, and dronabinol, may have varying schedules based on the formulation. Barbiturate schedules, Schedule 2, single entity oral formulations of amobarbital, pentobarbital, and secobarbital. Schedule 3, suppository formulations of amobarbital, pentobarbital, and secobarbital. Non-controlled substance in combination with amobarbital, pentobarbital, and secobarbital. Butylbarbital. Schedule 4, phenobarbital. Looking at codeine schedules. Schedule 2, single entity products. Schedule 3, combination tablets and capsules that contain codeine. For example, acetaminophen 300 mg, codeine 30 mg, or Tylenol number 3. Schedule 4, combination cough syrups that contain codeine. For example, promethazine, phenylephrine, codeine syrup. Dronabinol schedules. Schedule 2, oral solution, Syndrose, which is 50% alcohol. Schedule 3, oral capsules, Marinol. Then we're looking at Cannabidiols and Tetrahydrocannabinols. Federal law designates marijuana as a Schedule 1 controlled substance. Cannabidiol, CBD, and tetrahydrocannabinol, THC, are natural compounds found in the Cannabis sativa marijuana plant. THC has a psychoactive effect, a high. CBD does not cause a high, but can have an anxiolytic relaxing effect. Hemp is derived from a type of cannabis, which is a sativa plant with levels of THC which are less than 0.3% and are incapable of causing a psychoactive effect. Both THC and CBD are used for a variety of medical conditions with and without proof of efficacy. The ratio of THC-CBD contributes to a product's therapeutic efficacy and psychoactive effect. Then we have FDA-Approved Products, which is Epidiolex or Cannabidiol. The first FDA-approved CBD-derived product is indicated for seizures associated with several disorders: Lennox-Gastaut syndrome, Dravet syndrome, and tuberous sclerosis complex. Initially, the DEA placed Epidiolex in a new classification of Schedule 5 that would include FDA-approved CBD drugs containing no more than 0.1% residual THC. However, in 2020, the DEA descheduled Epidiolex, so it is now considered a non-controlled drug according to federal and California law. There are also 2 FDA-approved cannabis-related drugs, for example, not cannabis-derived like Epidiolex. We have dronabinol, a synthetic delta-9 tetrahydrocannabinol, synthetic THC approved for AIDS-associated anorexia and chemotherapy-induced nausea and vomiting, CINV. It is available as an oral capsule. Marinol, Schedule 3, and an alcohol-containing oral solution, Syndrose, Schedule 2. Nabilone, Sesamet, Schedule 2, a synthetic cannabinoid with a chemical structure similar to THC that is indicated for CINV. Regulation of cannabis products in California. So in California, cannabis is regulated less stringently. Medical use of THC was decriminalized in California back in 1996. Then in 2014, non-medical use of cannabis and cannabis products for adults was permitted. So CBD and THC containing products, including edibles, can be manufactured and sold. In states where recreational and medical marijuana is legal, such as California, CBD derived from the cannabis plant is taxed and regulated. Products derived from industrial hemp are regulated in a different manner than is derived from cannabis. In 2018, the Farm Bill was signed into federal law. This removed hemp from the definition of marijuana under the Controlled Substances Act. Since hemp products are legal, CBD can be extracted from hemp and then used in topical products such as cream, oils, and sprays. The FDA still regulates hemp and hemp-derived products, but they are no longer classified as Schedule 1. This has allowed retail pharmacies to begin selling hemp-derived CBD-containing topical products in select states, which includes in the state of California. However, hemp-derived CBD-containing products cannot be sold for oral consumption. Since pharmacies are registered by the DEA, they must operate within the confines of the federal law regarding marijuana. As such, pharmacies are not permitted to sell marijuana or drug paraphernalia, for example, rolling papers. Even though marijuana is not dispensed in pharmacies, pharmacists should add marijuana to a patient's medication profile and be aware of potential drug interactions. CBD and THC are CNS depressants, which can cause additive side effects. Both are also substrates of several cytochrome P450 enzymes, for example, Inducers decrease and inhibitors increase CBD/THC levels. Patients who are terminally ill qualify under the Compassionate Access to Medical Cannabis Act to use their medical cannabis within healthcare facilities with few restrictions. For example, smoking/vaping is prohibited and must be stored in a locked container. This concludes Chapter 5. The next chapter is going to be Chapter 6, which will be Part 2 of Controlled Substances. We're going to get into ordering and disposal in that next section.